I'd like to turn it over to Carl Hull. Carl.
Thanks, Andy. It's goodbye here. Well, thank you very much, Andy. It's a pleasure to join you today. And I have the, I guess, dubious distinction of talking about a topic as you're eating lunch that may seem a little bit incongruous, and that's going to be sexually transmitted diseases. So before I do that, let me explain why I'm doing this to you at lunch, and then we'll take it from there. Curiously enough, we're talking about advanced technologies and how they're applied to women's health care. But in fact, one of the longest standing areas where that has been occurring has been in the screening of sexually transmitted diseases. Molecular genetic technology, much of which you'll hear about in a few minutes from some of our patient advocates, has made huge differences in the treatment and the care of patients with many advanced diseases, many complex cancers. But in fact, its earliest applications were to identifying sexually transmitted diseases, particularly in settings where a patient doesn't know that they're either infected or at risk. And so I'm going to be telling you a story that's been evolving over the past 20 years, but it's one where these technologies have made a huge difference and continue to make a huge difference in women's health. A little bit about Hologic GenProbe. We're a company that was formed by the acquisition of GenProbe, where I was CEO just recently in August by Hologic. Taken together, we are the world's leading women's health company. Our company is the market leader here in the United States in technologies as diverse as mammography of a variety of kinds, including the newest generation of 3D mammography, or 3D tomography, that actually improves sensitivity and specificity in breast cancer screening. We're very active in a number of related fields, including bone densitometry, as well as diagnostics, as you'll see here. We focus on technologies that are used in screening, and screening is a little bit different than diagnostics. The main distinction being, you think of a diagnostic when you're sick, you have a symptom, and you go see a doctor. Screening is when you appear to be absolutely fine, but in fact something's going on that you need to be aware of, and we focus on less invasive technologies. So let me just give you the nomenclature to make sure that it doesn't confuse us later in the discussion today. What's a diagnostic test? Very straightforward. It is a test that's performed on a sample, in this context, taken from a human body, anywhere you may be. We also call it IVD, and particularly when you're on the Hill, you'll hear that term IVD. It refers to in vitro diagnostics, but it's human healthcare testing. Test results primarily are used by physicians and other caregivers to really determine how they're going to treat a particular patient. We answer questions for a physician like, is a disease present? Is it progressing, or has the course or its manifestation somehow changed? As the Congressman indicated, these tests are performed in a variety of settings. The two most common settings are centralized laboratories. So again, in terms of advocacy here on the Hill, you'll hear people from reference laboratories, and these are the major centralized laboratories where the majority of testing is done. A large volume of testing is also done in hospital laboratories, so it's a captive lab within the hospital where you're either a patient or where you're being seen by a physician. There is a bunch of other testing that's done in physician offices. You see it, you go in for a rapid flu test, rapid strep test, these kinds of things. Clinics, it's not uncommon, especially say if you have diabetes, the diabetes or endocrinology clinic will do testing on site in that clinic. And then finally, as Congressman mentioned, you'll see home testing, pregnancy, and certainly ovulation are areas that are quite familiar for all of us these days. Andy alluded to the fact that diagnostics value has been well established, and we firmly believe that. But we also think it's often overlooked. When you think about spending on diagnostics in our total healthcare spend, it is a small proportion of total, but it's a small proportion that guides the vast majority of clinical decision making. So for last year in Medicare, I think sub 2% of Medicare spend was on diagnostic testing, yet that influences as much as 70% of the actual decision making that goes on. So you get quite a bang for the investment, but it's not often understood how pervasive the influence of diagnostic medicine may be. And tests fundamentally are these days being developed to match the right patient to the right treatment at the right point in time. So within the world of STDs, and let me just jump right into this with apologies, I want to show you an indication of how widespread sexually transmitted diseases are in the United States. This pyramid shows the estimated number of new infections by various sexually transmitted diseases each year here in the U.S. Now, the thing that jumps out at me about this is if you look at the top of that pyramid, you can see the sliver that's green. That's HIV. HIV is a very serious healthcare threat, about 50,000 new infections per year. But if you think about our policy debate over the last 20 years, public policy, healthcare policy, access to care, new therapeutics development, all of these have been centered in many cases on HIV, and appropriately so, as we saw a disease that was once lethal now move into a disease that can be managed and people can be cared for almost normal lifetimes. So we've seen a huge shift and a huge amount of attention paid to HIV, but in fact, it is one of the least frequently transmitted sexually diseases in the United States, or less frequently transmitted STDs, and I will use STD to refer to sexually transmitted diseases. Down at the bottom, the very large slice that you see there is a disease called trichomoniasis, which is, I'll be talking to you more about, so I'll just save it for there. But this is the most widespread STD in the U.S. that you've never heard of, and we'll talk about the reasons for that. But other diseases, including HPV, human papillomavirus, which we know is the causative agent of cervical cancer, and Bonnie will be addressing shortly, HPV, at its heart, a sexually transmitted disease. And then you can see as you go down the frequency, you have chlamydia, herpes, gonorrhea. And let me address chlamydia now because I think it's a good model for understanding. Chlamydia is one of the most common and most easily curable sexually transmitted diseases that we have. Over 2.8 million cases were reported to the CDC last year. And this is a reportable disease. This is a very important distinction in public health because when you have a disease that's reportable, you also must follow certain treatment and follow-up guidelines, which is a good way to make sure that you eradicate that disease. The incidence is pretty low overall. It works out to about 0.4% in the total population. But if you look at the chart at the bottom, and you can see on the right-hand side, if the print's a little bit small, the bars reflect incidence in women, and on the left-hand side, they reflect incidence in men, and then we go through different age cohorts. So chlamydia is primarily a disease of women, and it's primarily a disease of young women. And that's an important factor as we think about how we treat this. Cases of chlamydia continue to grow, up about 5% since 2009. So I'm sure we all wish the economy were performing that well, but this is a very effective STD. The disease, as I said, is curable. A Z-Pak, those of you who've had a recent sinus infection will have had azithromycin. It cures chlamydia as well. And interestingly, one of the things about the disease is sometimes people have it and get cured of it because they've got a cold, and that's a good thing. And since it's so easy to treat, one would think it's an easy disease to eradicate, but it's hard to find, and that's the central point. If you're not screening asymptomatic patients, those who have no symptoms at all, then you're not going to find and be able to treat the disease. If you don't, long-term consequences of infection with chlamydia are pelvic inflammatory disease in about 40% of women, infertility in about 20% of women, and a high risk of ectopic pregnancy. Now, let's stop for a second on the infertility question. Since I just showed you that this is a disease of women and of young women, a 20% risk of infertility imposes huge downstream burden on the individual patients, but also expensive cost on the healthcare system as people try and cure that infertility. And unfortunately, with chlamydia infection, if you're pregnant and untreated or undiagnosed, about greater than 50% of all babies will be born with a chlamydial pneumonia or chlamydial eye infection, which can be treated but can be serious. The CDC recommends screening for chlamydia. That's why we do it, and that's why it's widespread in this country. But I would tell you that even with CDC recommendations and some others that I'll show you in just a second, only about 35% of women who should be screened according to the guidelines are in fact screened. So consider that. Only 1/3 of the women who should be tested are. So there's a great deal of occult disease that we're not finding today. The people that should be tested are all sexually active women under the age of 25 and those over 25 who are at risk because of a new sexual partner or multiple sexual partners. There's only one technology, and that's how I started this discussion, talking about molecular testing technologies. This is the only technology that's really suited for screening purposes. And the reason for that is we're using DNA technology that can be exquisitely sensitive, meaning it can find the earliest signs of infection. Therefore, we're able to pick up these diseases in women who have very low disease burden, a low level infection, who would never be symptomatic. But these tests are expensive. They're complex to do, and they're much more expensive than alternative methods. Yet for screening purposes, the CDC recommends only using the more expensive nucleic acid test because that's the only one that makes sense for screening purposes. And importantly, it is recommended that women be retested 3 months after they've been treated to make sure that the cure has taken. And a central concern here is the evolution or presence of drug-resistant disease. I'll talk more about that in the case of gonorrhea, but the fact is you've got to make sure that the patient is cured if you really want to do the job. Other areas where chlamydia screening is recognized as the universally accepted practice, HEDIS, AMA, the College of Preventive Medicine, all recommend screening annually. And even the USPSTF, as much as they come out against screening and certain other modalities, fully supports chlamydia screening, and ACOG recommends it for all pregnant women as well. So with the advent of the Affordable Care Act, chlamydia screening will be offered with no copay required for patients because it is a grade A under the USPSTF effectiveness guidelines. Gonorrhea is the second most common bacterial STD, so both are transmitted by bacteria. But the drug incidence that I mentioned, you may have heard about. There have been some news stories of late about some strains of gonorrhea that have actually resisted treatment with every known antibiotic. A lot of this is because resistance evolved because patients were not successfully identified and treated, and this is becoming a key concern. You can test for gonorrhea at the same time, and I'll show you that in just a second. But in particular with gonorrhea, just like chlamydia, people can be infected and not have any symptoms, but in the carrier state in gonorrhea, they're much more likely to transmit the infection to a sexual partner, so it's a more dangerous infection to be carrying around. Incidence is fortunately lower, and similar to what I just showed you, it's about 0.1. So if you think again, the whole population, 0.4% for chlamydia, 0.1% for gonorrhea. These seem like low numbers, but you can still see the effect of a disease more predominant in women and more predominant in younger women. But in this case, there are actually more men infected with gonorrhea, relatively speaking, and it's also a disease that affects older groups of patients in their 30s and into their early 40s, as contrasted with chlamydia. About a 3% growth rate of this disease since 2009. In summary, if I told you anything about why we bother screening and why we bother applying advanced technologies to this area, it's this chart. Either chlamydia or gonorrhea will cause, at different degrees of frequency, pelvic inflammatory disease. Once that is developed, any of those consequences that I mentioned, infertility, ectopic pregnancy, and I didn't mention chronic pelvic pain, and about 20% of women will occur as a result of the infection. And then, of course, for both diseases, it is possible that the infection will be transmitted mother to child at birth. So that's why we do what we do. The cost effectiveness of this has been extremely well established. To give you a feeling, and these are dated data, I believe, going back to 2005, chlamydia costs about $3.5 billion a year this year to screen and treat in this country. But chlamydia screening reduces the incidence of pelvic inflammatory disease by 60%, so it's effective. Every dollar we spend on chlamydia testing and treatment saves $12 downstream, much of that as a result of not needing to treat patients with pelvic inflammatory disease and the associated complications. And the nucleic acid tests that I mentioned to you work beautifully in this setting, and that's why this is really a success story that dates back almost now 15 years to the introduction of the first nucleic acid test here. The other thing that we're able to do with this advanced technology, which is pretty exciting, is we can screen for both infections at the same time. So my company offers a test that in one test tube at the same time will tell you whether or not you have the presence of gonorrhea or chlamydia. So effective screening programs can be done in one go, if you will. And thus, as a result, you're able to figure out how best to treat your patients. So I'll close by talking about these two little guys that you see up on the screen. As I mentioned earlier, Trichomonas, as this parasite is called, is the most widespread STD, and very few people understand it. Those are the actual parasites themselves that are the causative agents here. It's the most common, and it is equally curable sexually transmitted disease. But what's interesting about Trich, and refer to it as Trich as a shorthand, is that this disease is treated by one antibiotic, and it's an antibiotic that nobody ever gets for anything except a Trich infection. So you're not going to be exposed to an antibiotic that works against this parasite, and that has an important point that I'll share with you in just a minute. Also, this is not a reportable disease to the CDC. So I mentioned earlier that gonorrhea and chlamydia are. The reason that Trich is not is up until now, we have not been able to screen effectively for Trich, and thus we haven't been able to do the normal public health interventions, which also include contact tracing and proof of cure testing. Trich is just like the other diseases, asymptomatic in about half of the women. And a recent study showed that about 72% of the male partners of women infected with Trich were also infected with Trich themselves. This is a higher rate of infection than we see in chlamydia and gonorrhea, and it's thought to be due to the fact that this is a parasite, and parasites are transmitted differently than bacteria. And the disease can persist for a long time. This is a hard disease to diagnose. It's often misdiagnosed. It can be part of other infections. A patient can be symptomatic and have Trich or have other infections. In fact, Bonnie's company makes a test that is very well suited for testing in the diagnostic sector and trying to figure out which infection a patient may have. But some of these earlier tests are not well suited for screening purposes, just for the reasons that I described earlier. You have to be highly sensitive so you can find very, very low-level infections. And as a result, there hasn't been any mandate for annual screening up until this point. Physicians have tested when they're doing diagnosis of patients and when they suspect a patient may be at risk for other diseases, but it's catch as catch can, and there are no national screening programs in place. The CDC recommends Trich testing if someone is symptomatic, and it also recommends screening for Trichomonas if the patients are at high risk for other infections. So the same behaviors that expose you to chlamydia and gonorrhea expose you to Trich. But this is what I alluded to earlier in terms of data that's absolutely intriguing. And I'll try to orient you to this. Along the left-hand side, you see prevalence, and then on the bottom side, you see different age groups beginning at age 18 to 19, going up to age 50 on the far right-hand side. The three colors are the incidence of disease of each of those diseases. The top one, the pink one, is Trich. The blue one you see is chlamydia, and the gray one down at the bottom is gonorrhea. So you notice two things, that as a result of effective screening programs and intervention, both chlamydia and gonorrhea incidence decrease as you get older. So you're able to identify these infections, you're able to correct them, and behavioral changes occur as you get married and become monogamous later in life, so the rate of new chlamydia and new gonorrhea infections fall. The top line, though, being Trichomonas, shows exactly the opposite behavior. And why is that? Well, what happens is about 8% of women at their early ages, 18, 19, are infected with Trich. As you get into their 50s, data show as high as 13% of women carry a Trichomonas infection. That would also mean there's a large number of partners who are equally affected. Simple reason, we don't screen for it. We don't look for the disease, we don't intervene, and we don't treat it. So rather than having an opportunity to tail down, this disease holds constant or builds up. This is the only sexually transmitted disease that is more common in older women than it is in younger women. And so it's quite an interesting consequence of not having had the tools really up until the last year or two to look for this disease in a screening setting. It's just like chlamydia and gonorrhea in terms of its impact on PID and downstream consequences. What is unusual here is that Trich also is more likely to cause premature birth and low birth weight infants. So actually the downstream consequences to a woman of childbearing age of this infection are worse than chlamydia and gonorrhea because of that risk of preterm birth. And we believe this to be an appropriate public health concern. It ideally fits into screening programs, and what you'll see over time is effort by the public health authorities to identify both budgetary and other responsibilities to add Trich to routine screening programs that are out there today. One of the more interesting things about Trich, too, and it will segue into Bonnie's talk, is that this infection actually makes the severity of HPV infection, human papillomavirus infection, worse. It takes longer to clear, and this is also a risk factor for cervical cancer. And so, now you begin to see that in women's health, many of these diseases cross lines from cause and effect and have a consequence, a knock-on effect for the other types of women's health issues. So I think with that, I'll stop and I'll turn it over to Bonnie. Thank you very much.